to see you again.
George.
How are you?
Good, thanks.
Just for our audience, just please let us know your name, title, organisation, who you're representing today.
Sure. So I'm Professor Andrew Wilson. Today I'm here as the chair of the Pharmaceutical Benefits Advisory Committee. I've been the chair for about, this is my 5th year, but I've been involved with the PBAC since the mid-90s.
Very nice. And your association with ARCS, how long has that been?
So I think certainly as long as I've been chair, ARCS has been inviting me along to meetings.
Very nice.
So at least the last 4 years.
And Brittany, welcome.
Thank you.
Again, please let us know who you are, your role.
Of course. So my name is Brittany Schoeninger, and I'm an associate principal leading the Australian real-world late phase team for IQVIA.
And your association with ARCS?
It's been several years, pretty much been coming to the annual meetings ever since I moved to Australia.
Very nice, thank you. All right, well, we've just presented the session on real-world evidence and how this is being used in the pharmaceutical listings in Australia. So Andrew, maybe I can start with you. So how can the health technology assessment process and the listing process, say, be improved through the use of real-time evidence and data in the new technologies?
Yeah, so George, the point that I was making in the presentation is that I don't see this as something which is new. We've actually been using this sort of data for years. And in fact, we've been using linked data sets for a long period of time. So the only new thing about this from my perspective is the name that we happen to have given it as real-world data and real-world evidence. Of course, because of technology changes, we're able to produce this data in a much more timely way, and our ability to be more comprehensive about these data collections has improved, and our analytic capacity with this sort of data has improved. But it's been there for as long as I've been associated with the Pharmaceutical Benefits Advisory Committee. There has been some forms of what is now called real-world data as part of the decision-making process.
And Brittany, when you presented earlier, how do you see the HTA and listing process and the real-world evidence?
Yeah, so I completely agree with everything that Professor Wilson has just said. In my view, randomized controlled trials have been and will continue to be the gold standard, given the strong internal validity afforded by the prospective design, well-defined endpoints, randomization, and blinding. It provides us with a really strong, unbiased view of a treatment's impact within a clinical trial population. But I would argue that RCTs aren't without their own limitations. In particular, with their strong internal validity, they may have less reliable external validity and generalizability to a broader real-world population. And I think that's where real-world evidence has a strong role to play. And I would argue that there may, even with these limitations, be a standard above the gold standard, a platinum standard, so to speak, that combines randomized controlled trial data with real-world evidence.
And just to stay with you for a moment, Brittany, in terms of best practice around the world, what's the evidence saying in how we're incorporating real-world data into those processes?
Yeah, so we're increasingly seeing real-world data being used to support both regulatory approvals and pharmaceutical listings from an access perspective. So to give you one example, take the case of Bavencio or avelumab, which is one of the PD-L1s that's being used to treat Merkel cell carcinoma. So Bavencio was launching with a single-arm phase 2 trial, and the manufacturer made a strategic decision to complement that evidence with a real-world external comparator that was basically comprised of 2 retrospective observational studies that enabled comparison between how patients are performing on today's standard of care chemotherapy versus how patients perform on Bavencio. And as a consequence of that, it's effectively enabled access to Bavencio for Merkel cell carcinoma patients around the world, largely as a result of that strategic use of real-world evidence.
Andrew, just back to the PBAC and how it's adapting to incorporate the new technology solutions to continue to provide our universal healthcare and timely access. Do you see the greater involvement of the clinical and economic evidence from that perspective?
So it's critical to remember that as a reimbursement authority, as a funder of pharmaceuticals, our information needs are different to those of a regulator. They're not miles apart, but the threshold that a regulator may use is quite different to what a funding body might use in making a decision. essentially a regulator wants to know that it's safe and it works. It's not actually that particularly interested in the comparative effectiveness of the agent which is being provided. Whereas a funder wants to know about the comparative effectiveness of it. And the challenge is that, as we've seen, a number of drugs, and Brittany's just described that well, in Merkel cell carcinoma, these drugs coming to market with really very early phase data in a sort of traditional terms of the way we think about this, where the quality of that comparative data can be quite limited. And so what we then see is people trying to applicants trying to create comparative situations. So by using indirect comparisons, by using historical controls, for example, as parts of the way to construct that comparative element, which is critical for a reimbursement authority in making its decision about whether it wants to fund it. And there are many challenges in that. But one of the things that the improvements in the collection of this effectively observational data, which is occurring, is that we should be able to move to much more timely data, and therefore, for example, when we're using things like historical controls in that way, we should be able to get we should be able to get more recent data in terms of what practice is happening now versus what's happened in the past, where sometimes there's been a 10, perhaps 5-10 year lag between what the historical data that's being used in the comparison and what we're actually seeing. And given the pace of change at the present time, that doesn't give you a lot of faith in what you're looking at.
I'll just continue with you, Andrew, for a moment and just ask, in terms of the real world data, how is the patient experience or the consumer's contribution to that data set helping with the decision-making process? Or is that a gap that we should be doing more of? And how do we use that?
Well, the PBAC clearly has invested a lot more energy in trying to encourage a consumer input which is informative to its decision making. And the point that I've made is that it's not about the number of submissions that we get saying this drug should be listed. We can see that the number is really almost unrelated to the importance or of the disease in some ways. It's related to other factors which generates enthusiastic responses. But most of that information that we get is actually relatively uninformative to the sorts of decisions that the PBAC has to make. And what we're trying to do is we're trying to communicate to the patient and consumer organisations the things which help us better understand the consumer and patient perspective on this. So, for example, understanding better what particular changes, for example, on an outcome measure that might be used, understanding what people think that those changes actually mean. If you've got a continuous distribution, something like, for example, when you measure depression, where people frequently use a scale which may go from 1 to 100, what does 4 points versus 40 points mean on that scale? What do people think it means? What do consumers mean? And what do they experience that change as being? That helps us to understand the value of the medicine in a comparative sense. So we're trying to help. We're trying to ensure that the information that we're actually getting from patients and consumers actually addresses the sorts of things that are important in making our sorts of decisions.
Now, Brittany, you presented some results on the IQVIA survey of some 200 odd Australian physicians. Can you expand a little bit on what you found on their perceptions of real world evidence and how it may influence their clinical decision making?
Yeah, absolutely. So the results of the survey that you've just alluded to were overwhelmingly positive, basically indicated that more than 90% of Australian GPs agree that real world evidence is important, and nearly 90% also agree that they're currently using it to inform their clinical decision making. And when we drilled down a bit deeper into that, the latter of those particular findings, we saw it's really mainly examples where there have been high profile publications of real world evidence where it's having a major impact on prescribing decisions today. So You can take the case of the CVD Real study in diabetes, where it's informing prescribing of SGLT2s. Likewise, we saw frequent mention of the NOACs, and this is probably largely driven by the fact
Can
that
we just explain to people NOACs, the acronym?
the novel oral anticoagulants.
Okay.
So this is probably largely being driven by the fact that Professor Andrew Sindone of University of Sydney and Westmead Hospital has been quite vocal in promoting the complementary role of real-world evidence in informing prescribing in this space. So yeah, overall we're seeing a high level of interest amongst the clinical community in RWE to inform sharper evidence-based decision-making.
Okay. Well, I mean, it seems that the challenge is to translate real-world data into real-world patient benefit. So maybe as a concluding remark, as we end this fireside chat, maybe Andrew, just some final thoughts on that challenge of translating real-world data into real-world patient benefit.
Yeah. So the things that I've talked about today in relation to this is it's about the information, the data being fit for purpose. It depends on what question you're asking.
Yeah, exactly.
And if you're asking the right sort of question, that's where so-called real-world data is relevant, then you'll get very good results. So the sorts of things that Brittany was just referring to, for example, with NOACs, where you get this much narrower therapeutic profile, where you have a narrow therapeutic profile, then understanding, for example, the difference between what that might mean in a trial situation versus what it means in the real in clinical practice in the real world can be quite different, because the patients that we select to go into trials tend to be weller, they tend to be have less comorbidity, they tend to be younger, and yet when we go out into the real world, the patients who'll get treated with that will have multiple morbidity, they'll be older, and that therapeutic window, that therapeutic profile might be quite different in that group because, for example, of a different adverse risk profile associated with it.
And Brittany, concluding remarks on your presentation?
Yeah, so I guess the key theme of my presentation is to strategically consider integrated cross-functional evidence planning that incorporates real-world evidence early in your drug development to ensure that by the time you get to market, you're well prepared with your evidence supply chain fully built to enable you to put the best evidence package forward to the PBAC. And we know naturally that having the right evidence package will translate to timely access to the right medicines for the right patients at the right time, which is, to me, what real-world patient benefit means.
Well, thank you to both. On behalf of ARCS, Andrew, Brittany, I thought it was a great session, and thank you for your time today.
Thanks, George.
Thank you, George.